Good morning. I'm Dr. Bob Bank. I'm the medical director for the South Carolina Department of Mental Health, and our telepsychiatry programs come under my purview, and we're going to give you an update today about our programs pre-COVID and what we've done during COVID. If you have some questions during the presentation, there is a chat box available. So we will move on with the slides here. So as many of you know, the South Carolina Department of Mental Health has been one of the largest providers of telemedicine services in South Carolina for over 10 years. And we are the largest provider of telepsychiatry services. Our service lines have recently been expanded to 8 different programs, and I'll mention several. Our largest are the emergency department telepsychiatry and community telepsychiatry programs. Our emergency department programs serve 25 emergency rooms around the state, 24 hours a day, 365 days a year. Pre-COVID, we'd been seeing about 600 visits a month in that program. And our other large program is our community telepsychiatry, where we serve our 16 mental health centers with remotely located psychiatrists in order to increase our psychiatric manpower and access for patients. And prior to COVID, we've been doing about 3,000 visits a month. More recently, we've added an inpatient telepsychiatry program at our Bryan Psychiatric Hospital and a nursing home telepsychiatry service at our Tucker Center. So those programs have added some dimensions to what we've been doing, and hopefully will expand over time. But taken together, pre-COVID, all of our programs were totaling about 3,800 visits a month. And over the past 10 years, we have nearly totaled 150,000 visits prior to the COVID epidemic. Our experience in telehealth pointed us in the right direction when COVID came in February and March of this year. As soon as HHS opened the audiovisual and phone contacts for billing and for seeing patients, our psychiatrists continued on with what they had usually been doing, but we also were able to add master's level counselors. So in order to reach all of the patients that we have on our rolls, and we generally in the community have about 60,000 active cases at any one time, our number of telehealth visits increased nearly 3 times after March of 2020. We deployed equipment, including tablets, phones, computers, laptops, to more than 850 additional clinical staff so that they could work from home or work from our clinics and reach our patients in their homes if they weren't able to come into the clinic, or we didn't want them to come into the clinic. Prior to the pandemic, as we mentioned earlier, SEDMH has been providing about 3,800 telemental health services a month, and subsequent to March, that's increased to almost 15,000 services a month. Additionally, we've been reaching a lot of patients by telephone. That's a result of patients often not having a video component available, or they're perhaps just not comfortable with that kind of interaction, or they may not have the bandwidth available. So we've done about 268,000 telephone services between March and the present time in order to reach our patients. In looking at our emergency department telepsychiatry, if we look at March 1st, prior or just a little bit after the pandemic had started, we were seeing about 20 patients a day in the emergency rooms around the state. During the next 6 weeks, that trailed off and hit a low point of 6 patients on one day in April. So we weren't sure exactly what was going on with the numbers of patients we were seeing in the ER. We speculated that people were perhaps reluctant to visit the ERs for psychiatric problems due to COVID. But then after about mid-April, we saw the numbers start to come back up again, and we've just about reached our 20 visits a day as we have moved forward into the summer and now the fall. We are seeing our numbers remaining pretty steady for emergency room consultations. The biggest impact, of course, has been on our community telemedicine, telehealth programs. When you look at the number of patients that we saw in 2019 through this particular set of data, which runs from about March 1st to July, you can see that we actually contacted more patients during COVID than we had the year previously. And we attribute this to the fact that we were able to reach patients in their homes. And our population often has a difficult time getting in because of transportation issues or childcare issues or various medical illnesses. So this has actually given us an opportunity to learn a new set of skills and be able to reach people in their homes. So we really feel like the experience we had in telemedicine has really served us well in being able to react to the pandemic and jump right into using all these platforms to reach our patients in their homes. We did continue to see patients in the clinics, particularly those needing long-acting injectables or emergencies. And that's slowly increasing during these fall months with a few more patients coming in. But we continue to heavily rely on a variety of telehealth platforms. I think this really speaks to the need to reach patients in their homes for a variety of reasons. Patients are often unable to make their appointments, and this would be an excellent way to address that kind of issue of no-shows or inability to get into the clinic in the future once the pandemic has passed. So we're hopeful that CMS and HHS will continue to allow us to use at least the audiovisual platforms going forward after the pandemic. So what are the things that really made a difference for us? I think the thing I've emphasized along the way here is our previous experience and our confidence in using telehealth platforms. We were actually able to reach all of our patients except for a small fraction, less than 1%, during this time. And we had initially been really concerned about how we would reach everyone. So we've really risen to the occasion, and our counselors who didn't have a lot of experience in telemedicine really just jumped right in and worked with the different platforms and amplified our reach tremendously. We're also exploring the various platforms we've used the Doxy platforms of various types, Zoom when we need to, and a number of other AV platforms. The benefits of e-prescribing have certainly become more and more evident. Our e-prescriptions have shot up tremendously, and it's been really fortuitous that technology is mature and we're able to get those prescriptions out to patients. And I think we've really seen the need for outreach, particularly during this time. Patients are isolated, and we do get a chance to see more of their family members and do some family interventions that aren't as easy to accomplish when folks are coming into the clinic and usually coming by themselves. And I think lastly, I just want to mention that I think this points up the need for us to develop some more easily accessible video platforms for patients. Many of them don't have bandwidth capability or have the proper equipment in their homes. I'm sure there's going to be many innovations coming along based on our experience here with COVID. So with that, I'll finish up. And as I said, if there's any issues or questions, the chat is available. Thank you for your attention.
Hello, my name is Sarah Goldsby, and I am the director of the South Carolina Department of Alcohol and Other Drug Abuse Services. We are the state's single state authority for addiction services, covering prevention, intervention, treatment, and recovery services. I want to encourage everyone to use the chat box. If you have any questions during the presentation, I'll be happy to answer them in real time. Today, I'm going to share a little bit about our system, where our public system has been with telehealth before COVID-19, and how we've shifted and how we're using telehealth now to deliver services, and what we're really thinking about when we look at possibilities for the future. Many of you know that our publicly funded addiction treatment system is unique. We have 32 county alcohol and drug authorities that serve all 46 counties. We also have 22 private opioid treatment providers in the state that have become our subcontracted service providers in the last 3 years. With this system, around 43,000 South Carolinians are treated for substance use disorders annually. We have had some strong telehealth capacity in our state, and for all the reasons that you know, our General Assembly has made it a priority, and we've had the strength of the South Carolina Telehealth Alliance behind us for some time. With an award from the U.S. Department of Agriculture and some of DEOTA's support, our county alcohol and drug treatment sites all got equipped with telehealth carts in 2015. With the hardware in place, DEOTA's has also been subsidizing broadband costs since 2016, really helping our local county authorities a little bit with their telecom costs to ensure that they are all capable to connect to the state's telehealth network. For some rural agencies, this has been really critical support. So we've had the infrastructure, but before March of this year, there was no Medicaid reimbursement for rehabilitative behavioral health services. There was only reimbursement for some medical services. Over the last few years, we had been building this telehealth capacity primarily for medication-assisted treatment services, particularly to get services in locations where we've had a hard time recruiting physicians for regular practice and medical practice treating addiction. So we've had the technology in place for several years for medication-assisted treatment. It's really been limited even there because our state's Board of Medical Examiners has required a petition and approval of each physician or nurse to engage in medication-assisted treatment practice by telehealth. And until March of this year, only 9 prescribers were authorized to initiate patients on the important medication buprenorphine by telehealth. So this is just a glimpse of some of the carts in some of our local county alcohol and drug authorities. Now, in March, DEOTA's began to allow reimbursement for our providers to deliver certain services such as crisis management, individual therapies, peer support services, and case management, both by telehealth and telephonically, to make sure that we were able to maintain distancing efforts and safe clinic operations as isolation began at the start of COVID-19. And we've really got to thank our colleagues at the Department of Health and Human Services for joining us and working on their end to make sure Medicaid reimbursement for these services was turned on. It has really been a critical action to ensure service accessibility and availability. Now, recognizing many patients wouldn't have cell phones or enough data or service plan to support therapeutic services, we also allocated funds to our providers for them to purchase phones and minutes or data cards for the use of those patients in need. Additionally, with the Public Health Emergency Declaration, our Board of Medical Examiners issued an order allowing more prescribers to initiate medication-assisted treatment by telehealth without having first seen the person in person first. And so we continue to work with the board directly to petition those providers for approval. And we've largely been able to avoid any barriers for patients getting into medication services, and those who are already in services has been maintained very well. So what does behavioral service delivery really look like now? Well, currently many services in our treatment system are being delivered by counselors and clinicians and peer support specialists from either their office or from their home as they use laptops, cell phones, and the free secure platform Doxy.me to connect to patients. Again, if we hadn't taken these steps early on, we are certain that more of our patients and practitioners would have had even higher risk of exposure and illness from COVID-19. And in fact, we think some services might have shut down completely without this capability. Aside from the clear safety from COVID-19, we've seen other positive results using telehealth for the psychobehavioral and the medical appointments. We've been able to retain patients despite changes with the office or clinic location closures. And engagement of existing patients has actually increased because getting services at home or wherever the patient might be really eliminates typical challenges, challenges with transportation or finding childcare. Additionally, we're hearing from clinical staff that they are able to get deeper with patients one-on-one when they're at home. Providers can see the environment that the patient is living in, and some patients have actually invited family participation and connection to the clinician in the service encounter. Overall, most patients are reporting high satisfaction with teleservices, and they're saying that they wish to continue these services in some manner. But we've had some challenges. Our top challenges are around group therapy. We have not approved reimbursement for therapeutic group services by telehealth. It's been a tough decision because we know that many individuals need so much more connection than just individual therapy. And many patients have reported a desire to stay engaged in a group. And that's more than just the mutual aid groups that are largely accessible online. Treating substance use disorder is really a relational and a clinical experience. If we were confident that a high quality therapeutic group setting could be cultivated in a virtual platform, then it would be easy for us to approve reimbursement. However, we've just not found solid clinical guidance on virtual practice, and we believe that quality of group services on such a platform would be varied and questionable in some cases. Aside from clinical concerns, there are technological concerns, with dropped connections and other difficulties that we know occur. And then there's the confidentiality issues, of what might happen when a group therapy session is invited into several patients' homes all at once. Right now, we believe that the risks of doing group services by telehealth really outweigh the consequences of moving patients into individual therapeutic sessions. Another challenge is really just the uncertainty of the future. The telehealth services that are currently possible are time limited to the expiration of the declared public health emergency. And our providers and even our patients, feel a bit of anxiety and fear that these services will just end very abruptly. So when we're thinking about the future, several matters come to mind. We all recognize the greater need for services, with all of these confounding variables really driving the prevalence of substance use disorder. We know that South Carolinians are going to be needing more services in the future. And I just mentioned everyone's feeling nervous that the approval to treat and the reimbursement for telehealth will suddenly end. So we're very hopeful that policies will be put into place to ensure these vital services continue to be authorized. Particularly, we'd like to see all health plans include telehealth modalities as reimbursable benefits. And we're hopeful that the current policies that ensure access to these vital services could be included, across all health plans and extend beyond the emergency declaration for COVID-19. And there has to be more conversations ahead, around how authorizing practitioners to treat patients via telehealth really protects the public by enabling access to critical kinds of care. And finally, but most certainly it's not last on our list as we think about the future, we've really got to keep addressing the barriers that prevent our vulnerable and disadvantaged populations from accessing telehealth services. And this has a lot to do with technology and internet connectivity in our rural and in our low-income communities. So I'm very encouraged to hear the conversations happening around the State House, in Washington, and with the stakeholders really here at this summit, that are focused on access and equity. And I thank you all for listening today. And again, I'm happy to take any questions in the chat box. Thank you.